Good morning, bonjour, buenos dias, and good afternoon and good evening wherever you may be. My name is John Balbus. I'm Senior Advisor for Public Health for the National Institute of Environmental Health Sciences. Co-chair of the Institute of Environmental Health and Sustainable Development Innovation. It's my pleasure to greet you and to welcome our speakers on this webinar entitled Integrating the Millennium Development Goals with the Pillars and Principles of Sustainable Development. This is our second webinar in a three-part series that's coordinated by the Roundtable on Environmental Health Sciences, Research, and Medicine of the Institute of Medicine. And I want to acknowledge my own institution, the National Institute of Environmental Health Sciences, for support of the webinar series, and especially thank PAHO for providing the setting and the technology and the expertise to get this out onto the web so everybody now can be listening. I also want to acknowledge the planning committee for the webinar series. And extend our thanks to Guto Gaval of PAHO, Dr. Bernie Goldstein of the University of Pittsburgh, Frank Loy, chair of our roundtable, Kumanan Razanathan, Lucila Spinney, and Judy. By no means least, I want to extend my thanks to the Institute of Medicine staff who have done such organized our roundtable staff leader, Christine Cousins, and Aaron Rush, who have done the yeoman's work in getting this together. So for those of you coming in for the first time, I just wanted to say a few words about the webinar series. The overarching goal of bringing us all together is to try to improve the performance and the outcomes of sustainable economic development by making sure we eliminate the critical linkages between sustainable development and environmental health. We have a short-term target, which is to try to inform the current UN-led process of creating sustainable development goals. And these webinars are designed to provide the kind of scientific information about how health and sustainability are linked, and also to offer some new ideas on how we can integrate environmental health into the targets, into the indicators and metrics of all the relevant sustainable development goals. Last month, we had our first webinar that provided an overview of the lessons learned from the Millennium Development Goals and the process of working on those. And also, last month, we discussed the UN process of developing the post-2015 goals, currently being called Sustainable Development Goals. Today, in our second webinar, we have three outstanding speakers to take us more in depth how we might operationalize this idea of integrating environmental health concerns into the Sustainable Development Goals. Next month, we'll focus more on the intersection of equity, social justice, environmental health, and sustainable development. So just as a taste of the kind of issues that we're talking about, I thought I'd share this word cloud that Aaron has provided us based on the survey that everybody who registered on the web has to complete. And for those of you who haven't seen one of these, this is a kind of a visual way of depicting the frequency and the emphasis placed on specific words in any kind of set of text or set of responses. So look at this. We see strong themes of future environment and development. Of interest, the word climate change doesn't appear. The word health is very small. The word exposures doesn't appear. So this is an interesting starting place, and I hope that as we go along that we see this balance between the issues of environmental exposures and the health outcomes linked to them, issues of social justice, of climate justice, climate change, and sustainability. In some ways, the word cloud highlights some of the challenges that we face in this. We discussed last month how the Millennium Development Goals created these sectoral silos that made a lot of intersectoral coordination difficult. So what we're trying to do and what we'll be talking about today is achieving really true multidisciplinary collaboration in these new international processes to develop the Sustainable Development Goals. And as I said, it's a challenge. That's why we're doing this. Moreover, in the current global financial and economic scene with strong concerns about financial issues, it's clear that the efforts we make have to make more than just common sense and more than just public health sense. They also have to make financial sense. So we have to be focusing our discussion and our efforts at integration on things that will create real synergisms, real benefits that can leverage financial investments in the different sectors, or else to make sure that we avoid hidden and unforeseen costs, which is what we've seen too many times in sustainable development, not well informed by environmental health issues, is hidden health costs that were not predicted or not recognized in the process. That's what we're trying to do. We have to be thinking about this not just in terms of public health, but also in terms of economics and finance to be effective. Can I have the next slide? So before we go on to our first speaker, I just wanted to share with you a new newsletter that the National Institute of Environmental Health Sciences is pleased to be launching this week. Our GEH news is now on the web, and those of you who are interested can subscribe at the URL listed at the bottom. And with that, it's a real pleasure to introduce our first speaker, who I'm sure will get us started down the right path of intersectoral collaboration, and that's Professor Andy Haines. Sir Andy Haines is a professor of public health and primary care with joint appointments in the Department of Social and Environmental Health Research, and also in the Department of Nutrition and Public Health Intervention Research at the London School of Hygiene and Tropical Medicine. Previously, he was the director of the London School of Hygiene and Tropical Medicine for nearly 10 years, and also worked part-time as a general practitioner in North London for many years. Professor Haines' research interests are in epidemiology and health services research, focusing particularly on primary care and on the study of environmental influences on health, with a lot of work outstanding work on the potential effects of climate change and also on the health co-benefits of a low-carbon economy. So, Professor Haines, I'll turn it over to you.
Thank you very much, John, for the introduction. And it's a great pleasure to join this webinar today. So what I'm going to talk about is the importance of bringing together health and sustainable development using the example of strategies that both reduce greenhouse gas emissions and also improve health. I think we do have a new window of opportunity here with the review of the MDGs and the opportunity to integrate through the proposed Sustainable Development Goals, health and broader development issues. So could I have the next slide, please? This slide really just summarizes some of the potential projections for CO2 emissions over time. And you can see that there are different scenarios based on the Intergovernmental Panel on Climate Change in 2007. Different scenarios as shown in the colored lines on the graph. The black line is what's actually being observed, and what you can see is that the black line is towards the upper end of the distribution, and that suggests that the temperature by 2100, for example, may be much higher than today. It looks as though it's going to be extremely difficult to keep within 2 degrees centigrade, which is the limit that many climatologists think above which you get dangerous climate change, by which they mean various increase in extreme events, wide-scale melting of ice caps, and so on. So it's very important to try and reduce greenhouse gas emissions really quite dramatically. And in order to do that, industrialized countries like the UK and the US need to cut their emissions by perhaps 80% by 2050. So quite a substantial challenge ahead. And it's often perceived that that kind of challenge is very difficult politically, it's costly and so on. But I want to put a slightly different argument today to say that there would also be many benefits from moving down that low-carbon economy, that low-carbon trajectory in the future. Next slide, please. I want to just very briefly outline a few case studies that we've done over recent years which exemplify what kind of benefits, we call them co-benefits because they're kind of ancillary benefits that arise from greenhouse gas reduction strategies. And of course, they would be additional to any benefits that would occur from reducing climate change itself. In the studies that we've done, we've looked predominantly at 4 sectors: housing, transport, food and agriculture, and electricity generation, in both low and high income settings. And in each of those, you can find strategies which can result in substantial reductions in greenhouse gas emissions, but also improve human health, in some cases in the relatively short term. Next slide, please. So as you can see, in order to reduce the probability of dangerous climate change, we need to make this quite dramatic cut, certainly in the emissions of industrialized countries. And so what we did was to model the effect by 2030 of a 50% cut in emissions for a country like the UK, which would take us along this trajectory to an 80% cut by 2050. And for the different scenarios, we looked at both the greenhouse gas emission implications of the strategy as well as the human health implications of the strategy in question. Next slide, please. The first sector I want to briefly outline was household energy. Now, in a country like the UK, we have many very inefficient houses, and this photograph on this slide, the thermal imaging camera, shows you the house on the left, which shows you a lot of heat escaping through the walls and windows, and on the right you've got a modernized house with double glazed windows and inner wall insulation. And the study that we did modeled the effect of improved household energy efficiency and ventilation control, because one of the issues is that as you seal up houses and you reduce drafts and heat loss, of course you can increase indoor air pollution. So, for example, the concentration of indoor tobacco smoke, environmental tobacco exposure, fine particles, some of which may come in from outdoor air pollution, radon in some parts of the world as well. So it's important to consider not just insulation, but also ventilation control. And it's possible to design very energy efficient ventilation control improvements. And the modeling that we did assumed that the most tightly sealed dwellings were also subject to a modern high efficiency ventilation control. And including all these modifications, one might avert perhaps 5,000 deaths a year in a country like the UK. That doesn't take into account perhaps some of the benefits from addressing cold, which is a problem in the UK and indeed in the US. But it does give you some indication of the number of premature deaths that might be averted by a strategy to modernize the housing infrastructure of a country like the UK. And this would result in saving perhaps 55 million tons of CO2 compared with 1990. Could I have the next slide, please? If we look at low-income countries, and this is where it's particularly relevant to the Millennium Development Goals as they're currently configured at the moment, we see that indoor air pollution is a major risk factor for acute respiratory infections in children, but also chronic obstructive pulmonary disease in women, and indeed also probably for ischemic heart disease. It causes around about, I think, 2 million premature deaths a year. And the case study that we undertook some years ago, Paul Wilkinson and Kirk Smith led this case study, was looking at the health and greenhouse gas benefits of an improved Indian cook stove program, which involved rolling out 150 million improved efficiency stoves over 10 years. We thought that was actually feasible. It sounds very ambitious, but the Chinese did something rather similar in the 1980s. They rolled out about 100 million improved cook stoves over that period. If you look at the effects in a country like India, such a program could avert perhaps 2 million premature deaths over the decade, mainly in women and children. And the slide really compares the traditional open fire or very inefficient cook stove with a modern cook stove which can even gasify biomass and other fuels. Doing this combines reductions in greenhouse pollutants such as black carbon, methane, ozone precursors, perhaps up to 1 billion tons of CO2 equivalent over the decade, and combines that with averting all these premature deaths. So that obviously directly impacts on some of the MDGs, particularly the MDGs around child mortality, in those countries where much of the poorer part of the population uses either open fires or inefficient cook stoves. And these stoves are relatively cheap, less than $50 per household over 5 years. Next slide, please. Moving on to another sector, to the urban transport sector. This is important because it's responsible for a large and growing amount of greenhouse gas emissions in many countries. We see urban transport has effects, of course, on air pollution, on road traffic injuries, and, of course, very importantly, on sedentarism. And as we know, of course, obesity, diabetes going up in many parts of the world, many other conditions related to sedentary lifestyle. And one of the most practical ways of increasing people's physical activity, of course, is in their habitual activities of daily living, particularly walking to school, to their work, and to the shops and so on. And that is becoming increasingly difficult, of course, in many urban environments. So what we did was to model the effect of a couple of different scenarios. We called them increased active travel and low carbon driving in cities of London and Delhi. I won't go into the assumptions in detail, but broadly they assumed more efficient cars, but also increasing the use of cycling and walking for short distances. So we assumed, for example, a city like London, people might cycle for the average distance they do in a city like Copenhagen, where they cycle on average about 3 kilometers a day, something of that order. So we looked at the health impacts of introducing these new strategies to reduce greenhouse gas emissions, but also to have impacts on health. Next slide, please. And what we found, to cut a long story short, was that the biggest effect was because of increased active travel, because sedentarism is such an important risk factor for about 7 major conditions. Some of them are shown on this slide. Ischemic heart disease could be reduced perhaps by up to 19%, according to the scenario that we developed. Stroke by a similar amount. Dementia, somewhat smaller. Breast cancer by an appreciable amount. Not shown on this slide, but still important to diabetes, depression, and bowel cancer, all of which, according to a number of epidemiological studies and systematic reviews, are related to sedentary lifestyle. Now, of course, you may get increased deaths and injuries due to increased road traffic crashes as more people cycle and walk, even if you reduce road vehicles. But what you can see from this slide is they're vastly outweighed by all the benefits that would occur. So although there might be a small increase in deaths in a city like London, there are many, many more deaths prevented as a result of increased active travel. And that's even more striking in the case of a city like Delhi, where the projections for the future are of very large increases in private car use for short distance travel. Next slide, please. We've also recently looked at the possibility of averting health service expenditure as a result of these kind of strategies. And this slide just shows you the potential annual NHS, that's National Health Service expenditure, averted by year and by health outcome from this increased active travel scenario. And what you can see is that the blue line, diabetes, is the most important thing that's impacted upon, because diabetes is so costly to the health system. People with diabetes live for quite long periods, an average of perhaps 16, 17 years, and over that time they accrue a lot of cost for the health system. So if you can prevent some cases of diabetes, then obviously there are potentially big savings for the health system. And we estimated perhaps 17 billion, it depends on the assumptions, perhaps 17 billion pounds over a 20-year period or so, and the amounts might continue beyond that, will continue beyond that 20-year period. So fairly substantial savings over time, and these were probably relatively conservative because we didn't take into account the effects of obesity. We didn't want to be accused of double counting. So potentially then large savings to the health system, but also improvements in labour productivity and other social benefits as a result of these policies. Next slide, please. Moving on to the food and agriculture sector, currently, as I think it's generally recognized, we have quite, on a global level, quite a dysfunctional food supply system globally, where perhaps 1 billion people are suffering from hunger at the same time as obesity is growing around the world. We're feeding perhaps 40% of all grain harvested to animals. And of course, livestock are also the major contributor from the food and agriculture sector to greenhouse gas emissions. So it takes about 8 pounds of grain to produce 1 pound of beef, for example. And ruminants are also the main source of greenhouse gas emissions, particularly through methane, which is a potent greenhouse gas. Next slide. This slide just illustrates how animal production is related to greenhouse gas emissions, and makes the point from modeling study that we did a couple of years ago that if you could reduce animal source saturated fat by 30% in a country like the UK, you could reduce deaths by about 15%, and it's a similar proportion in a country like Brazil. We did a similar exercise in Sao Paulo. So it's important to improve the efficiency of energy use in the agriculture and food sector, but from our analysis, we felt that this would not be sufficient to achieve the kind of targets, to achieve the kind of reductions in greenhouse gas emissions that would be needed to stabilize the climate. And therefore, in high-consuming countries like the US and the UK, it was difficult to avoid the conclusion that we would need to reduce animal product consumption, but there would be some health benefits from that. And indeed, we didn't include all of them. We didn't include the positive benefits from increasing fruit and vegetable consumption, for example. Next slide. Finally, electricity generation is the final example of my four. And this slide just summarizes the relationship between, on the vertical axis, the health burden, on the horizontal axis, the equivalent carbon dioxide emissions from different sources of electricity generation, so different fuels used for electricity generation. You can see very clearly from this graph that lignite and coal, and to a lesser extent oil, are very strongly produce large amounts of greenhouse gas emissions, but also produce large health impacts as well, both in terms of cases of serious illness from air pollution, but also from accidents and so on. Nuclear is at the bottom of this slide. Obviously, nuclear is controversial for other reasons because of waste, potential of accidents, and so on. Renewables not shown on this slide. If they were, if, for example, solar was shown, then it would clearly be at the bottom corner with below gas and around nuclear, because solar and many other renewable technologies don't produce fine particulate air pollution, which of course is the major killer from the combustion of coal and lignite. Next slide. And of course, there are a range of new technologies coming on stream, renewable technologies for clean energy, which offer great promise of reducing CO2 emissions, but also reducing fine particulate air pollution, and thus reducing the health burden from outdoor air pollution. So there are major potential sources of energy. It's been suggested, for example, that placing solar concentrating power panels, which are illustrated in this slide, where the solar energy is concentrated on a vertical tower containing molten sodium, which then drives turbines, generates electricity, that the whole of the electricity supply of North Africa and of Europe could be pretty well covered by solar concentrating power in North African deserts, if there were the appropriate investment made. Next slide. So I think what we can say is that there are policies, a range of policies in at least these four sectors and possibly others as well, that can help us address both public health priorities and promote sustainable development, particularly by mitigating climate change. But if we consider the impacts of these policies on both environmental goals and health goals simultaneously, this will make them much more attractive than focusing on either in isolation. I think from my presentation you can also see the potential for some metrics and goals, which will be the topic of a later presentation, which could combine public health and sustainable development, for example, around indoor air pollution, around active travel, around low carbon generation of electricity. So there are potential for developing these metrics, which represent both sustainable development targets and public health targets. The health gains associated with these mitigation policies are additional to benefits from reducing climate change. And of course, these healthcare benefits can help avert health service costs and also offset the costs of low carbon policies. So I'll stop there. Thank you very much for giving me the opportunity to say a few words, and obviously very happy to respond to questions when we get the moment, an opportunity to do that. Thank you very much.
Very much. It was a wonderful talk, and as as you mentioned, we will hold on questions at this point, and we will ensure that we have a good amount of time at the end to have all of our speakers and our organizing panel and some of our roundtable members available to have a panel discussion at the end. Professor Haines has laid out for us the intersections between other sector sustainable development issues, looking at agriculture, looking at transportation, looking at energy production, looking at housing, and the modeling studies that you've shown, the data that you've shown are really critical and really first glimpses into the kinds of tools that could be used to help hone indicators, to help prioritize the specifics of some of these sustainable development goals in these other sectors in order to achieve these co-benefits and to optimize population health, which of course feeds back and promotes more sustainable and more robust development. So we'll now go to our second speaker, Dr. Kristie, who will turn this kind of in the other direction and look at how many of issues of sustainable development and climate change circle back to global health issues and to some of the global health Millennium Development Goals, and how do we now incorporate sustainable development into them. Dr. Ibai has been conducting research on the impacts of and also effective adaptation to climate change for more than 15 years, primarily dealing with extreme events, thermal stress, foodborne diseases, and vector-borne diseases. She's worked with the World Health Organization, with the United Nations Development Program, the International Development Research Center, and USAID, the Agency for International Development, as well as others in designing and implementing adaptation measures both in low-income countries as well as work that she's done, some of which in partnership with the Center for Climate Strategies, on identifying adaptation options for U.S. states that I've been, over the last few years, conducting vulnerability and adaptation assessments. Dr. Ibai, I'll turn it over to you.
Thanks very much, John. I really appreciate the opportunity to join the webinar, and thanks to Andy for an absolutely excellent presentation. As John mentioned, I was asked specifically to focus on how the MDGs could evolve to better align with the principles of sustainable development. So if we go to the next slide. Well, these were supposed to come up one at a time. I was wondering if that was going to work. I'd like to make 3 points before I launch into why these are important. In thinking about how to move the MDGs in alignment with sustainable development, I realized it's not specific tasks that need to be undertaken, although there are tasks that do need to be undertaken, but much more broadly to start thinking differently. The MDGs, the upper left-hand corner, are a series of gears, just to remind me to say that much of the work that was done on the MDGs, highly critical, very, very important work, comes out of an engineering approach to the world that developed societies right now follow this kind of, they implicitly follow this perspective that we can identify a problem and then find a solution. That if a part in my car doesn't work, I go down to my mechanic and he knows how to fix it. That there's very fixable solutions to the problems that arise. The chair is to remind me to say that we also tend to take an approach in public health that one size fits all. Just like my office chair is supposed to fit everybody who can sit in it, that we identify a problem, develop a vaccine, find a drug, and we go out and implement it. And we do that in a way that's pretty much a top-down approach that has worked incredibly effective for a wide range of issues. And this is why the MDGs and other aspirational goals from public health take these two kinds of approaches. The third is, they're not Andy's grain silos, but they're to indicate that over the 150 years that public health has been trying to improve the health of the populations around the world, that typically it's been done within public health. There's limited reaching across to the other sectors and working with them on trying to improve the situation in a much more holistic sense than just focusing on achieving a specific outcome. So if you go to the next slide, one of the main points I want to make is there is a term that's used in social planning called wicked problems. And you can see on the slide the description of what a wicked problem is. For those of you who worked in climate change, you can immediately recognize why this applies. Wicked problems are problems that are difficult or impossible to solve because of incomplete, contradictory, changing requirements. In climate change, it's also the high levels of uncertainty we have about how specific changes will occur in the atmosphere and what those changes will ultimately mean at a particular location at a particular time. In addition, because these problems are so complex, efforts to solve one part of a wicked problem can cause problems somewhere else. We're seeing this in climate change with efforts undertaken in one sector, such as agriculture or water, then having effects on human health. We cannot take action independently of what's being done in other sectors. And so the final conclusion is with climate change, we can only make problems better or worse. And that it's our responsibility as public health professionals to ensure that we do everything that we can to help make problems better. So if you go to the next slide, I want to focus on one of the MDGs and talk about how climate change is likely to interact with it and why achieving the current targets will be a challenge, and to think then about what that means for moving forward to sustainable development. For those of you who haven't seen World Mapper, some very clever people realized that they could scale the size of countries by other factors than their geographic size. They're wonderful ways to communicate information. This is the current situation around the world in terms of underweight children. You can see that Target 1C is trying to have, between 1990 and 2015, the proportion of people who suffer from hunger. And it gives you the numbers up there that 50% of all children less than 5 who are underweight live in Southern Asia. So we know where the problems are. And if you go to the next slide, this shows you progress that has been achieved, at least up to 2007. And the red areas are the areas where there is no progress or there's been deterioration. So it's being very difficult. There's a lot of challenges to try to achieve this particular target. If you go to the next slide, this is some work that's been done by David LaBelle asking how has climate change affected current crop production, particularly the cereal crops. So this shows you the observed changes in temperature over 1980 to 2008. And you can see, if you remember the previous map I showed, that many of the places that are having challenges achieving the target 1C are places where temperatures have gone up. And if you go to the next slide, it shows the impact of those increases in temperature on crop yields. It shows maize, rice, wheat, and soy. And it shows that there's been a reduction for many of these in many regions of the world. Some places have seen increased production. Warmer temperatures have been beneficial to wheat in the U.S. and Canada. There's been some benefit for warmer temperatures for wheat also in Australia. But if you look at maize, for example, has also gone up in India. But you start seeing that rice has gone down in a number of areas. So there's already been impacts of rising temperatures on crop yields. As you go to the next slide, this is from the Intergovernmental Panel on Climate Change Fourth Assessment Report. I took out the slide for rice. This is true for all the cereal crops. It shows the mean local temperature change by the percent yield change. The graph on the left shows mid to high latitudes. The graph on the right shows the low latitudes. And as you look across all the cereal grains, increasing local temperature will have benefits for cereal grains in the mid to high latitudes. In the low latitudes, any increase in temperature, you start seeing a reduction in those rice yields. I'm not going to talk then about what Andy spoke about of what we are feeding all these cereal grains to. This is just the fact that there is a real reduction coming in cereal grains in the places that currently have the biggest problems with undernourished children. And it's going to exacerbate the ability to feed those children. Then if you go to the next slide, and this shows some projections, one of a series of projections that have been done for coming years. What was done for this research is for the period 1985 to 2005. This is from Noah Diffenbaum, but a whole series of climatologists have worked on this. They identified the temperature that occurred once in 20 years. So you're looking at the top 5% of temperatures. And then said, how often would that temperature reoccur in future time periods? As you look at these maps, the ones down the left-hand side, they're both for June, July, and August. The ones on the left-hand side are for lower climate change at the end of the century. The ones at the right-hand side are for higher climate change at the end of the century. You can see the first row is just for the coming decades. It's 2016 to 2035, and then you have through the end of the century. If there was no change in the occurrence of these high temperatures, the map would be white. You could see that there's nowhere that there will not be a change in temperature. You can see that in Africa, even within the next couple of decades, a 40% increase in the recurrence of these very high temperatures. I have another map that's a little more complicated than this to explain that basically shows that these 1 and 20-year temperatures within a couple of decades will be occurring once every 3 to 5 years in many places in the world. And you think back to the graph that I showed from the fourth assessment report of how sensitive the cereal crops are to temperature increases, that in many parts of the tropics, they're growing right at the edge of their temperature tolerance. There's a lot of work being done on trying to develop drought and really salt-resistant crops. There's efforts on what can be done to try and improve crops in these rapidly changing conditions. And that's research that takes quite a while to find crops that will grow in these very different kinds of conditions. There's often an equally long period of time that's going to be needed to deploy these, to have the farmers be able to accept and start planting these kinds of crops. So you can see that climate change is presenting a significant challenge to achieving this MDG target. And as I mentioned before, these targets were set up thinking solely about how to solve the problem of so many undernourished children, using understanding at the time, but not thinking broadly across all of the systems that are being affected by climate change. And so this is calling public health to take a much broader perspective, to look beyond just the public health, to take a look at how our systems are changing, what that is going to mean, and how we can best manage these kinds of changes. What are the options for improving the lot of children around the world? So moving on, there's two other issues I'd like to talk about, and these are important independently and how they interact. We know that the number of undernourished children is not only determined by how many cereal grains are available. We know that there's multiple causes of food insecurity, and cereal grains are just one of them. But there's two other factors. One shown on this slide is malaria. We know that malaria and malnutrition interact, that undernourished children are more likely to succumb to malaria, and if they have malaria, they're more likely to be undernourished. This shows you the temperature sensitivity of the mosquito populations and the Plasmodium to temperature. We know that temperature and precipitation are important determinants of the geographic range and the incidence of malaria. They are not the only determinants, but they are important determinants. There's also an MDG on trying to reduce the number of children who succumb to malaria. So there's strong system interdependencies across these. And then if you go to the next slide, the third interdependency that comes in is diarrheal disease. Children who are malnourished also succumb more easily to diarrheal disease. Children who have diarrheal disease also then become malnourished. They don't absorb nutrients, so they become malnourished much more easily. We know that there's a range of environmental factors associated with diarrheal disease. One, as you can see from the slide, is acute weather events, floods in particular, and heavy rainfall. This is some work that just came out looking in the scientific literature and ProMed on accounts of this association. Warmer air holds more water. As the temperatures around the world have gone up, there's been an increase in heavy rain events. In the U.S., Canada, and Europe, there's been a 20% increase in heavy precipitation events. The number of rain events is the same, but when it rains with the warmer air temperature, you get much more rain, hence the number of flooding events we're seeing around the world. In the low-income countries, that's associated with more often outbreaks of waterborne diseases. If you go to the next slide, and these are projections of the risk of diarrheal disease with climate change, basically showing that as temperatures go up and there's more of these heavy precipitation events, also because many pathogens have a replication rate that's temperature dependent, that if you don't exceed the temperature within which they can replicate, the higher temperatures, heavy precipitation, you'll see much higher risks of diarrheal disease. Those risks don't have to be realized. It's well known how to prevent diarrheal disease, but actually getting the political will to have all children have access to safe water and improved sanitation, having the technologies has been fairly challenging. All of the excellent work that's been done to date is being challenged by climate change. As new regions are becoming susceptible to these, as the places that are currently susceptible see more challenges to controlling diarrheal disease. If you go to the next slide.
No warning.
Can you go to the next slide?
Chris, so this is John. I just want to give you about a 2-minute warning. I think we're in good time, but I just want to give you that warning.
Yep, we're in good time. And so when you're thinking about the impacts of climate change, thinking about how those impacts are going to interact with sustainable development, one thing that's been learned very clearly from the work that has been done is when you think about those impacts, they're a function of 3 factors. One is climate change and how it will play through changing weather systems and what that means for ecosystems and how they can support anopheles, for example. The second is who or what is exposed to those. We know that there are a range of measures that can protect from exposure to, for example, the sea level, from planting mangroves to a range of other factors to protect against sea level rise. And the third, and very important from a public health perspective, is the underlying vulnerability of the populations. The example here is from Zimbabwe. It shows you the largest cholera outbreak in Africa. It followed a heavy rain event. It does not take an extreme event to cause an extreme impact. The reason there was such a large outbreak was very high susceptibility from the very unfortunate status of public health in Zimbabwe. So if you go to the next slide, this is one of my last couple slides. Sustainable development, then, is a series of aspirational goals and a plan for how to get there. And usually these plans, as indicated in this slide, are fairly straightforward and look like they're kind of easy. But if you go to the next slide, reality is often quite a bit different. And certainly with climate change, we're going to see many surprises. We're going to see threshold crossed that we didn't know are there. There's going to be setbacks from factors we didn't take into consideration. There's going to be interactions across food, water, energy that are going to be surprising. And so what this really calls for is a flexible approach to set these goals, but to have a tremendous amount of flexibility in revising them, addressing challenges as they arise. And if you go to the last slide, I just want to thank you very much.
Wonderful. Thank you for a really excellent presentation and helping to, again, take a look at global health priorities and some of the global health priorities that may be part of the post-2015 SDG process, and bringing the perspective of climate change impacts and how the future needs to take into account sustainability in a much different way than we've been thinking about it in the past. So it's now my pleasure to introduce our third speaker, Professor Chris Murray, who is Professor of Global Health and Director of the Institute for Health Metrics and Evaluation at the University of Washington. A physician and health economist, Dr. Murray's work has led to the development of a range of new methods and empirical studies to strengthen the basis for population health measurement and to assess the cost effectiveness of health technologies. Dr. Murray worked at the World Health Organization from 1998 to 2003, where he served as the Executive Director of the Evidence and Information for Policy Cluster. And from 2003 until 2007, Dr. Murray was the Director of the Harvard University Initiative for Global Health and the Harvard Center for Population and Development Studies. So we're very fortunate to have Dr. Murray with us today, and I'll turn it over to him.
Thank you very much. Next slide, please. So what I'd like to do in this presentation, next slide, please. Thanks. Is use the about to be released Global Burden of Disease 2010 study to sort of say what's the current evidence on some of these linkages that we've been talking about between health and the environment. And I think the results from that are a little bit different than what we've heard, but I think are complementary. Then brief discussion of desirable attributes about proposed metrics for the future, and then just some thoughts that are pretty similar to what Andy Haines had to say, but go in a few different directions. Next slide. So the Global Burden of Disease 2010 study, which will be released in a dedicated issue of The Lancet in December, in about a month from now, is the sort of latest version of a 20-year effort to systematize the evidence on the state of health around the world by disease, injury, and risk factor. And in the current guide, it has 291 diseases and injuries and 67 risk factors. And it's at the country level, and it's over time. And I think the perspective of looking at change in health over time will be very important for thinking about some of the issues that might be important in the future as we think about the post-2015 agenda. Next slide. So there are three large drivers of change from the period 1990 to 2010 that's being studied in detail. two of them are pretty well known. One is the demographic transition, namely larger population size and an older population, and that has pretty profound effects on the leading health problems. The second is the cause of death transition, where there's a marked shift away, with a few exceptions and important ones like HIV, but a marked shift away from burden from communicable diseases like diarrhea or pneumonia to diseases that are more characteristic of young and middle-aged adults, particularly non-communicable diseases. And the third major transition, which is less well known, is the progressive shift of the importance of disabling conditions that don't necessarily kill you, mental health, substance abuse, musculoskeletal disorders, as causing a substantial fraction of the burden of disease. Next slide. So just to shift by age, in blue on this slide is the fraction of DALYS, that's disability-adjusted life years, a measure of healthy years of life lost, capturing both premature mortality as well as illness. And the blue is the fraction of DALYS in 1990 by age and sex, and the red is in 2010. And you can see over a 20-year period the pretty impressive shift away from burden in children, although there's still a lot in children, towards burden in young and middle-aged adults. And that shift is moving at a very steady pace, so we can expect decade by decade that graph to progressively shift to the right. Next slide. Now, this slide is showing what I mentioned on the disability transition, namely in orange here is the fraction by 21 regions around the world of the burden of disease that's attributable to disability out of the total. And in 1990, going from the most developed regions on the far left to the least developed on the far right, we had a range from 10% in Africa to almost 40% in high-income regions. And now that's substantially shifted towards disability everywhere, with most of the more demographically and epidemiologically advanced regions, disability accounting for half the problems as compared to premature mortality. Next slide. Now, this is a complicated diagram that basically summarizes the changes in the leading health problems from 1990 to 2010. So it's a rank list in both periods of the leading causes of burden. And in fact, what you see in red are the communicable maternal neonatal conditions, things like pneumonia and diarrhea going down pretty noticeably. For example, over the 2 decades, diarrhea has reduced in terms of burden by about 50%, despite increases of population. So in terms of overall decline, that's pretty impressive. And you can see the rise in blue of the non-communicable diseases, so that the leading causes now are ischemic heart disease, then pneumonia, then stroke, although diarrhea is still number 4 and HIV is number 5, up from much lower in 1990. And malaria has stayed pretty similar in terms of magnitude. But the overall diagnostic here is this progressive transition that we're seeing played out over the last 2 decades. Note road traffic injuries, because I think that relates quite a bit to the transport agenda, is gone from number 12 to number 10, and that's an absolute increase in burden of about 34% over that period of time. Next slide, please. So the next slide here shows the current set of indicators, and it's a way to look at the fraction by region of the burden of disease related to MDGs 4, 5, and 6, and the fraction shown in green for 1990, and the fraction in orange shown in 2010, just highlighting that the MDG agenda is still very central for sub-Saharan Africa, but the MDGs only account for 20% or less of the burden of disease in 16 of 21 regions. So we've seen a tremendous amount of progress and a progressive shift away from what's been the MDG agenda, and I think raises issues for the future for the post-2015 agenda for it to be broadly relevant. Next slide. So here's, I think, probably the most important findings for thinking about the connections to the environment, and this is the assessment of the burden of disease globally attributable to different risk factors. And at the top of the list are things like high blood pressure and smoking and alcohol, but indoor air pollution, from, or household air pollution from burning solid fuels in the home is number 4 in the box there. Ambient air pollution, you can see farther down, accounting for 3% of the burden of disease, and physical inactivity just below it. Next slide. Just to point out on the ambient air pollution that the reason it, and actually indoor as well, but a different distribution, is so important is both the distribution of air pollution, but the concentration of it in high population dense areas, particularly in China. And that's a very key component of understanding the quite large burden related to ambient air pollution. Next slide. So continuing farther down the risk list, there's other risks that have a very strong environment/transport connection. So unimproved sanitation, about 0.6% of the burden of disease. Now that may seem much smaller than people expected, but that reflects the really substantial declines we've seen over the last 2 decades in diarrhea. It's going away at a pretty fast pace, about 3% per year, so that over 2 decades, it's really becoming much less of a source of burden. You saw that in the list of diseases, and we see this pretty much everywhere we look at the data, that despite setbacks in some settings in terms of cholera epidemics, those are rather small compared to the total burden of diarrhea. And in fact, diarrhea is moving away at a fast enough pace that the burden related to unimproved sanitation and unimproved water sources is relatively small, but large in Sahelian West Africa. It's still the one place where it's really quite substantial. Notice also in this list of risk factors, lead is up on the list, about equivalent to unimproved sanitation, and then there's ozone down at the bottom as another example of an environmental link. Next slide. Okay, shifting gears to sort of, if we wanted to design new metrics for the post-2015 agenda, what are some of the attributes that we would really want to have for these metrics? Next slide. So I outlined 5 here that I think are pretty important. First, although there's an incredible array of indicators that people can think of for development, for the environment, for health, and where they intersect, I think what's important for the post-2015 agenda to have things that really are large, that have true population impacts, whether on health, the environment, or on social and economic outcomes. Secondly, I think there's always a tendency in the discussion around indicators to mix the issue of what's the indicator you really care about with the measurement strategy. And sometimes that leads people to propose quite distal proxies instead of measuring the thing that we actually care about. And I think it's really important, particularly for a long-running agenda, to measure the true quantity of interest and not some distant proxy. Third, I think that some indicators are problematic if they are not clearly interpretable. In other words, more is bad or good. Because sometimes people propose indicators where there's sort of a U-shaped curve, and those don't work very well, or much harder to communicate to a broad audience. The fourth on this item is the need, before one comes up with the proposition of a new indicator, to have a tractable measurement strategy, not necessarily one that you can do right now, but one that's achievable in a reasonable time frame. And lastly is the sort of political economy of indicators, namely it's particularly important for the post-2015 agenda to propose indicators that are not just relevant to a small group, even if it's very important for that small group of countries, because I don't think that will garner the sort of political buy-in and consensus that will be required. Next slide. Okay, so now to some specific and really quite personal proposals of areas that warrant attention in the intersection, mostly between environment and health. And this is really not terribly evidence-based, but based on sort of looking at the burden of disease work and having some knowledge of what might be tractable indicators. So next slide. One of the things that's really quite new in the GBD 2010 is the much larger magnitude of the harm related to PM 2.5, so particulates of less than 2.5 microns in size. And in fact, in terms of the total global burden of disease, these account both ambient and indoor, excluding the tobacco sources of particulates. If you put them in, it'd be even more, 6 to 7% of the total burden of disease. That's pretty huge, much greater, for example, than the entire HIV epidemic. And that, I think, is a clear area where the solutions are in the environmental arena. And you can imagine that some of the strategies to reduce PM 2.5, not all, would actually also reduce carbon emissions. And Andy spoke to that in his presentation. I think that it is feasible going forward, although somewhat complicated, to get real measurements of human exposure to PM 2.5. And that would be a tremendously useful indicator for which various environmental policies would affect these, and one would be able to trace out the harm in humans rather easily. Next slide. I think one that relates to both the burden of disease results for disease and injuries and risk factors is the whole notion of clean and safe transport. I think that's a very attractive area for an intersection between health and the environment agenda, because if you count up the burden related to road traffic injuries, ambient air pollution contributed by vehicle use, and lead from vehicle use, you get quite a substantial burden. And the types of investments required to improve or get clean and safe transport are really coming from the transport sector, from institutions investing in road infrastructure, but doing that, or mass transit systems, doing that in a way that will achieve both transport needs and clean and safe transport. And I think that can achieve both greenhouse gas type goals as well as health goals. And you could imagine an indicator that's something like the fraction of miles traveled using clean and safe transport. Complicated to calculate, but not impossible at all. And you could perhaps even go one step further along what Andy was saying, which is to capture the extent to which some of the transport alternatives were actually encouraging physical activity as well. A little bit trickier to roll all that into one indicator, but worth exploring. Next slide. One that Andy also hinted at, and one that I've been very intrigued about, is sort of rethinking the notion based on the new science around diet components of how we relate, quote, healthy diets to the way foods are produced and distributed and sold. In the past, I think the message on diet was about salt, sugar, and saturated fat. And interestingly, it whizzed by quickly, but in the burden of disease, the latest systematic reviews don't show that saturated fat is actually harmful as compared to any other source of calories. So if you substitute carbohydrates for saturated fat, you don't actually have health gain. So the sort of great harm related to saturated fat evidence is not so strong anymore. And in fact, in our long list of diet components, we don't have saturated fat because of the negative systematic review. But there's lots of components of diet for which there's positive evidence. Fruit, nuts and seeds, whole grains, fiber, and vegetables in that particular order. And you can imagine both agricultural policy and tax and subsidy policies that would encourage use of those. And you can imagine also how those themselves would also have environment benefits if one were to figure out how to do that in the right way. So an indicator that was really just tracking burden, number of years lost due to poor diet, might actually be, although it sounds like a health indicator, might be one that had a mechanism by which many environmental concerns were expressed. And my last slide, next slide, is, well, actually, one more after this, is that I think one measure, which sounds entirely like a health measure, but I think would completely open up the world to more of the connections between environment, social development, and health, is to have the sort of apex health indicator post-2050 being healthy life expectancy. It's an excellent summary of overall health. It's measurable. It is measured. It's available now for all countries from 1990 to 2010. And it reflects not just public health and medical care. In fact, many of the key determinants are things like educational attainment, environmental concerns. So it would be a nice way to frame health more broadly as an intersectoral concern, and in so doing also have encouraged the consideration of the overlaps. Now, for that very reason, I think there's some resistance from some organizations to the idea of using this indicator for post-2015 because it's not focused enough on medical care and public health. Last slide. This is just to show that, in fact, healthy life expectancy is measured. This is also going to be published in mid-December, the assessment from 1990 to 2010 and the change therein by country. And, of course, as you guessed, there's a huge range in healthy life expectancy reflecting both levels of disease and levels of mortality. The good news there is healthy life expectancy is now going up in most places in the last decade. And, in fact, almost all countries bar a small handful. And it is a measurable outcome that would be a broad integrative strategy for a number of sectors and their connection to health. So I'll stop there. Thank you for your time. Hello?
I thought it was great, Chris, but I don't know what happened to the audio.
Yeah, I think we may have lost them.
Well, I heard your entire presentation.
Yeah, so did I. I heard it very clearly, yeah.
Goodness.
I think we wait. It'll probably come back. Chris, I was interested in your comment about saturated fat, because I think that in 2009, we used a systematic review. I can't remember which one it was now, but it was the currently available systematic review that showed that if you replaced animal saturated fat with polyunsaturates, you did get a reduction in ischemic heart disease. What was the most recent one that you quoted?
So that's from Darius Mosafarian. I can get you the citation.
Yeah,
and yeah. To be precise there, the saturated fat substituted for carbohydrate, no benefit. Saturated fat substituted for polyunsaturated fatty acids, benefit, but that's because polyunsaturated fatty acids are a direct benefit, not because...
Yeah, no, I yes, and I probably should have made that clear in my first... Yeah, that's what we kind of assume. There are questions about how much we can...
Thank you, Andy and Chris. We've had some technical difficulties on our end with my microphone, but I just wanted to thank, first of all, Chris for an outstanding presentation, and let folks who are listening know that there's some similar efforts to some of the concepts that Chris was providing that came out of an expert workshop that the World Health Organization and NIEHS did and can be accessed at the World Health Organization website. If you Google health in the green economy. So I'll ask everybody to stand by. We're having some technical issues, and we'll come back and we'll have questions from the webinar. We'll also be joined by a number of other Innovation Collaborative members, by Maria Nero's World Health Organization, and Dr. Galbao of Tahoe.
John, it's Andy here. I have to leave in about 10 minutes, so I just wondered if I could just take questions first. That's all right.
Absolutely. If you can hear me, we'll just continue to go on while we work on, I don't know if people are having feedback problems.
Yes.
Okay, hopefully this is sounding better and working better, and let's start by just asking if there are folks on the phone who have joined us or roundtable members in the room who want to start with questions. And Dr. Goldstein has a question.
I hope this microphone is working. It's probably mostly for Andy Haines, but actually for anyone. We've had a lot of trouble trying to use economic benefits of averting disease because economists basically argue that there is no real economic benefit from preventing cardiovascular disease due to particulates because the person's going to die of something else. And there is still the same end-of-year life cost on the average. Economic benefit in the way that we traditionally have been trying to do in showing value of approaches. Comments on that counter argument. Andy, were you able to hear the question?
I heard part of the question. I'm afraid I got intermittent coverage, but shall I try and respond to what I understood to be the question?
So basically, the question is economists tend to deny that the economic benefits from health co-benefits are real. What would you say to that?
Well, I think it depends on the disease. I think it depends on the assumptions. And Chris Murray is probably in a better position to answer this than I am. But let me have a first crack at it. I mean, I think, first of all, you have to look not just at the impacts on the health system, but also on things like labor productivity, for example. So some of the more recent work we've been doing has been looking more broadly at the impacts on a macroeconomy of health co-benefits. And in doing that, we've shown that improvements in labor productivity can also be important. For some co-benefit strategies, these economic benefits can more or less offset the kind of costs. For others, that's not so. For example, in the food and agriculture sector, if you were to move en masse away from animal products into greater intake of plant-based products, then that would have probably negative economic impacts, at least in the short term. The other issue is of discounting, and of course, if you discount away many of the benefits, then of course that also makes any strategies economically less attractive. I think it also raises the question of to what extent we should be focusing our policies on GDP growth. I mean, GDP, as we know, is a very flawed indicator of the success of different human societies. And I think one of the issues is whether we should be completely beholden to GDP growth as the main indicator of economic success. And my own view is that we need to be looking more broadly at other metrics of the development of human societies, whether it be well-being, whether it be of health-related life expectancy, as Chris Murray has suggested. I think we can debate that. But I do think we shouldn't be completely enslaved to GDP growth as the only indicator of societal success. I think that's potentially quite dangerous. I think the big practical question is what we're going to replace it with, and will that be politically acceptable? I think it's going to take some time for the public to catch up with this debate and to take on board these issues about other ways of measuring the success of our societies.
Thank you, Andy. Did anybody else on the phone want to address that question?
Thought that the indicators that you raised, I could talk about those for quite a long time, but I just want to ask a question about PM 2.5 as an indicator. I thought that
linking that with the global burden of disease and its ascendance as a risk factor was very key. But the issue with PM 2.5 is that it's very cross-cutting. It is an indicator for a lot of different sectors that will likely be part of the SDGs. And my understanding of the Millennium Development Goals is that there was, an indicator was only an indicator for one goal. So do you have any I know that you're very involved in the SDG process. Do you think that in this next round we will have space for something like PM 2.5 as a cross-cutting indicator that has, its own intrinsic value as a health indicator, but is also connected to everything from agriculture to transport to energy production?
Chris Murray here. Excellent question. I think, going back to the MDG process, and I was involved at the time representing WHO in the discussions about indicator development. And to give you a little example on this, we actually persuaded in the process around the choice of the indicators around the Millennium Declaration to have an indicator of household air pollution, namely the fraction of households using solid fuels for cooking. And that was an MDG indicator, but it was listed, it's promoted by WHO, but it was under the environment goals and was never really owned. And actually, in the revision of the indicators, got dropped, towards the end of the 2000s. And so I think that lesson is instructive, that you need to, if you're going to have an indicator, especially one that is cross-cutting, it's got to appeal to enough groups to be willing to champion it, and it has to, there will be, as you say, a challenge in something that maybe isn't the number one indicator for a given sector, but does cut across many sectors. But one would hope that there's a way to try and use the connection across many sectors as a, something that's attractive this time around. But I think it's a real issue.
Thank you. Anybody else want to comment on PM 2.5, or even just this idea of cross-cutting indicators and as one way of we keep talking about the silos, and obviously indicators that cross-cut are one way of breaking those silos. Okay. If there are no other comments, I have a question from Anna Treasure, who asks that she would like to know your thinking for indicators for water and sanitation based on the updated Global Burden of Disease study. Should quality of water be measured to look for heavy metals, for endocrine disruptors, and other contaminants like that? And what would be indicators that would get at those kinds of issues of contaminated water?
I take it that's directed to me. So I think that the whole water and sanitation area is really interesting. Clearly, it's still a very big agenda, particularly in parts of West Africa, but still important in other places as well. But I think, in fact, the whole area, because of the secular trends in diarrhea, are so powerful, as far as we can see in the data, that if you look 10 years out, you will have diarrhea even another 30 or 40% down from where it is now. I don't actually think, from a health point of view, that one would want to argue for indicators for the post-2015 agenda around water and sanitation, just because I think that the trend in that is so favorable. I think you might want to argue about that for other reasons, to do with household well-being and access to clean water and use of household time and freeing up of women's time particularly. And I think there's where the sort of water and sanitation, but particularly water, might be framed as indicators that aren't so much health indicators, but have some link to health, but not a huge one. So it's a little bit of a counter to many people's natural instincts around water and sanitation, but it seems to be that water and sanitation, probably looking forward, wouldn't meet that first principle that I had, which was to focus on the really big things in choice of indicators, because there will only be a very finite number of indicators. On the other hand, I think it's really important to, if you're focused on water and sanitation as an intervention area, to, monitor those sort of programs appropriately. But that's a little different than choosing indicators to replace the MDG indicators.
Thank you. Other comments about this question, which was also getting, I think, at looking at contaminants of water that may be linked with other kinds of health outcomes other than diarrhea, looking at endocrine disruptors, heavy metals as contributors to cardiovascular disease, metabolic disorders, etc.
John, this is Chris. I'd like to provide a bit of a counter to what Chris just said. There are really very positive trends in diarrheal disease. As I indicated in my presentation, there's also these counter trends coming with changes in temperature and precipitation that we know affect how people use water. And it affects how people use water in ways that tends to increase diarrheal disease. And one of the questions becomes, do you want indicators that are only backward-looking, counting how well was done? Those indicators are needed. Also, indicators that are more forward-looking, saying we have projections of how water availability is going to change in a number of regions. And to be able to use those to set up preventive programs so that when you actually go back and count with your other indicator, you're doing a really good job. And to think about how these interactions with environmental variables could affect the progress, and on the other hand, to use these environmental variables for which we do have projections, to actively use those in designing our programs so that we can start looking at those places where progress is being made, but it looks like it's going to be much more challenging.
Thank you very much, Chris. Any other comments on this question? Okay, we'll go to our next question. This is from Marta Patricia Morales Gomez. And I'm going to take her question and maybe expand it a little bit. And she is asking about the healthy active life expectancy indicator and asks, what is the source of information about the HALE at the country level, and are there metrics available for this indicator at the subnational level? And I'll just kind of embellish that question a little bit and ask, how consistent across countries is this measurement in terms of its robustness and the kind of data that feed into it? And when we talk about the subnational level, there's a regional subnational level, but there's also demographics and subpopulations and the ability to look at HALE as an indicator of inequity within a country and get at equity and justice issues.
Sure. I think on HALE, it's a long discussion. That's a really excellent question. There are really two fundamental strategies for measuring HALE. One is, in addition to having mortality measurement in a life table, you need a measure of the prevalence of ill health and disability. And the two routes to that. One route is by doing a household survey and using one of the sort of health-related quality of life or health status instruments, things like SF-36 or, the long list of possibilities there. And then the other strategy, which is actually the one that I was showing and will be the one that's published in The Lancet in mid-December, is to construct up the prevalence of disabling conditions and ill health from prevalence numbers by disease and sequela. And using, what is the very rich data on a number of diseases around the world and constructing that up country by country. So the latter strategy is more analytically complicated, but is more robust in our view, and is one that is available, and all the details, will be published at the national level. Can it be done at the subnational level? Yes, I believe it can be, but that would require, it depends on the sort of data systems in a country. In a place with sophisticated data systems, Brazil, for example, I imagine that would be reasonably straightforward. In a place like DRC, I think it would be quite challenging at this point to do subnationally. I think there would be, the challenge of the first strategy, which sounds easier, just go to a survey and ask people, a self-rated instrument. There's many comparability issues with that, it turns out. And I think that would be challenging with our current knowledge of how to enhance comparability, whereas the way of constructing up from the prevalence of different diseases and injuries and their sequela, I think, is grounded in using the same case definitions, disease by disease and sequela by sequela, so that it's sort of intrinsically more comparable.
HALE as an indicator? Okay. We are nearing the end of our time, but I wanted to hand the mic, so the virtual microphone over to Dr. Maria Nera, the Director of the Public Health and Environment branch within the WHO, for some comments. Maria, are you on? Well, until Maria comes on, I'm going to ask a similar question, unless, is there anybody on the phone or in the audience who also has a question? Okay. I just wanted to ask a similar question about indicators. Sorry, this is going back to you, Chris, again. You mentioned a couple of other indicators which were also very intriguing and have a lot of importance. One on personal transport and the miles traveled by clean and safe transport, the other on diet. And I was just wondering if you could comment on the robustness and the comparability across countries of those kinds of indicators, since those seem to be very dependent on surveys of individuals, and they're expensive and hard to do. And even in the United States, we have pretty poor metrics of transportation choice. So how could we operationalize that in diet as well?
Another good question. So on the clean and safe transport front, I think that's definitely a new idea and one that would require mapping out a measurement strategy. I think the reality is that in every country in the world with some pretty high frequency, it turns out, if you look across all of them, there are household surveys. If you look at the latest library at, for example, the World Bank, most countries are averaging more than one nationally representative household survey per year, often many times more than one, if you look across sectors. Even within just health, we're average close to one per year for countries, and more than that in some places. So I think the issue of using surveys is not really so much of a challenge. I think it's really, would you be able to get good comparability and how you would just sort of manage the measurement task there. And then it may be that you could embellish what you require about personal behaviors and transport use with local measurement of how clean those choices actually are. So I think that's a tractable thing, but it would require some development work and thinking. I don't think the challenge is the surveys. As I said, it's really just mapping out how you would figure out the clean and safe part and marry that with consumer choice or behavior data. For the diet part, I think that's a little bit more straightforward because that's a little bit like healthy life expectancy, where you construct up that picture from data on consumption choice by households, and that comes from either food balance sheets as one crude source, which can be very useful, and then the sort of diet history, diet diary, reported diet consumption data that's collected in nutrition surveys and other sources. So you have two types of sources to get at the diet part that I think can be standardized more than they currently are, but also I think would be tractable. In both cases would require some planning and thinking and saying this is worth doing and important to do.
Thank you very much. We are
even more nearing the end of our time. Unfortunately, I think we were not able to get to a phone to be able to join us, but we will, Maria, if you can join us on
closing, please feel free to interrupt. But we will draw this to a close. Remind everybody that 1 month from today, on December, sorry, I don't have the date in front of me. I had to shift my location. Okay, sorry. Hopefully there will not be feedback for everybody, but we'll draw things to a close. I'll remind everybody that our next webinar will be devoted to a more focused look at social justice and equity issues. So with that, let me thank our speakers who have done a fabulous job today, and thank all of you for listening in, and we'll look forward to joining you again in a month. Bye, everybody.